Hello everyone, I am Dr. Ashwin Tamhankar. I am a consultant in Urological Oncology Division as a part of Cancer Division and Robotic Surgery Division of Apollo Hospitals, Navi, Mumbai. Today we are discussing about urinary bladder cancer. So basically urinary bladder is a reservoir which keeps or holds the urine for some time before we pass the urine. So filtration units of the body are the kidneys, and the kidneys drain into the bladder in the form of ureters, and urinary bladder stores the urine for some time. So any cancer arising from the lining of the urinary bladder is called as urothelial cancer or the urinary bladder cancer. So most importantly, incidence and prevalence wise, it is about 8th most common cancer in men, and females it is about 11th most common cancer. Most important risk factors are smoking and industrial exposure of chemicals. Smoking generally we calculate in the form of pack years, that number of cigarettes or number of packs of cigarettes smoked per day into the number of years. Higher the pack years, higher is the risk of having bladder cancer. That's why smoking is very notorious for development of the cancer. It is because of the chemical exposure or the chemicals in the form of tar or smoke are excreted into they are basically absorbed into the body through lungs, and they are excreted into the urine. As bladder reservoir stores the urine, it has lot of time for the exposure of the cell lining with those chemicals, and hence more chance of cancer. Similarly, other industrial exposure of chemicals in the form of petrochemical industries, rubber industries, dye industries, textile industries, glass factories, these are the individuals who have little high risk of having bladder cancers than the other individuals. The Indian situation, we are having similar comparison with the Western literature, and the bladder cancer incidence overall in India is increasing. The bladder cancer types are essentially in the either a standard urothelial cancer, which comes from the lining of the urinary bladder, or it can also come from the lining of the ureter. These are the draining channels or the tubes coming from kidney to the bladder. Or the second types of cancers are squamous or adenocarcinomas, so which are rare types. We are essentially going to talk about urothelial cancer. In a broader sense of demarcation, we can either qualify that bladder cancer patient as non-muscle invasive cancer patient or the muscle invasive bladder cancer patient. The term is self-explanatory. Whether the cancer is actually going to the muscle layer of the bladder or not, that is a demarcation point. The other nature is depending upon the grade of the cancer, which can be either low grade or high grade. So a management of a bladder cancer will be broadly divided into non-muscle invasive and muscle invasive phase. Let's discuss about non-muscle invasive phase first. In a non-muscle invasive bladder cancer, generally the aim is to try and preserve the bladder as much as possible. In muscle invasive phase, we may not be able to preserve the bladder to that extent. So in a non-muscle invasive phase, what we do is initial diagnostic procedure, which is cystoscopy, and a procedure to take the tumor out endoscopically through the urethra and the endoscopic way. It is called as transurethral resection of bladder tumor, TURBT. So cystoscopy and TURBT forms the first step of the management of the bladder cancer. It is a diagnostic step as well as a therapeutic step. By diagnosis is obviously diagnosis is going to happen when we have the pathology across. When we take the sample out, the pathologist tells us about the report. Pathologist tells us about the grades which we spoke about, high grade versus low grade. They also tell us about the depth of invasion between the superficial most layer or the muscle layer or the layer beyond the muscle layer. That is what is understood based on the pathology report. So once the muscle is considered to be free on the initial resection and we are trying to preserve the bladder in an individual, we have options of intravesical therapy, which is either in the form of BCG therapy. It's the same vaccine which we all got at the birth for prevention of tuberculosis. So the same vaccine is in a different manner is given in the bladder on regular occasions, which induces inflammation in the bladder, thereby prevents the cancer cells to come back. Because recurrence and progression are the two important terms which are important for decision making of non-muscle invasive bladder cancer. It generally tends to come back again and again. That is called as recurrence, and progression means it comes back in a stage which is little higher than the previous stage. And both these recurrence and progression, which we definitely don't want, and main aim of the therapy is to minimize the chances of recurrences and progression by giving some therapy in the bladder. which is either a BCG therapy, or the second option is chemotherapy. So that is called as intravesical therapy, which is BCG or chemotherapy. In addition to that, patient obviously requires regular check cystoscopies or the visualization in the bladder as a part of surveillance protocol, along with some battery of urinary tests for number of years or for the lifetime in high grade cancers, depending upon the requirements. And anytime whenever there is a recurrence, we obviously have to resect it, and depending upon the pathology, we have to take the subsequent calls. So that was pertinent to non-muscle invasive bladder cancer. One quick word on this: in a younger, fitter individual, if the risk factors are very high, there are certain lesions called CIS, which are flat lesions. So combination of high grade and CIS lesions in a younger individual should also merit or qualify that individual for a potential candidate for complete removal of the bladder even in non-muscle invasive phase, because that is the best opportunity of cure of that particular patient. So let's come to the second part of the discussion, that is muscle invasive bladder cancer. So as we can understand from the terminology, it has gone to the layer which is a solid layer of the bladder, and hence we may not be able to spare the bladder in that individual. So in that particular case, the ideal treatment option is complete removal of the bladder, that is called as radical cystectomy. We basically transect the bladder, take the prostate also out along with the bladder in men, and the lower part of the vagina in the females with the urethra in the females. After the entire bladder is out, the urinary channel has to be diverted, and that is called as urinary diversion. So the complete procedure of cystectomy is divided into the first part of removal of the bladder and the second part of reconstruction of the urinary channel in the form of urinary diversion. The reconstruction can happen in the form of either an internal diversion or the external diversion. So internal diversion is called as neobladder, generally reserved for fit and very young individuals. External diversion is called as ileal conduit, which comes in the form of a small pouch of an intestine coming to the side of the tummy on the side of the umbilicus, through which the urine is getting drained into a bag. So both these reconstructions or diversions are done with the usage of intestine by isolating the intestine and looping it with each other to form a kind of pouch or a reservoir. So that is what is urinary diversion means. It's a major surgery. The diversion part is also a major part of surgical intervention. Hence, it merits a lot of thorough discussion and a detailed patient understanding before we take the decision about the surgical aspects. But that surgery gives the best opportunity for that patient for the cure. Either before the surgery or after the surgery, chemotherapy has a definitive role in this particular segment to have the maximal potential for patients to stay alive out of the bladder cancer for 5 years and beyond. So the goal is to have maximal survival, and hence the chemotherapy is very much important here. Recently, immunotherapy has been launched for bladder cancer, and it is being currently explored for these category of patients. The third variety or third demarcation of a bladder cancer is a cancer which has already gone to the different body parts, that is called as metastatic bladder cancer. In metastatic bladder cancers, primary role is for the medical oncologist, and they manage these patients in the form of either chemotherapy or immunotherapy. From the urological oncology point of view, we probably have to look after the tumor so that it does not bleed much and take care of the requirements based on the patient's symptoms. A multidisciplinary team approach, or we call it tumor board discussion, is very, very important for all the patients, not just for bladder cancer, but for all cancers, to be honest. These type of multidisciplinary teams, cross speciality discussions happens between surgical side, medical oncology side, radiation side, the pathologist, the radiologist, the nuclear medicine team. So all 5-6 group of doctors sit together to make the plan for the patient, and that is very much important, especially for bladder cancer patients. So just to summarize, smoking is a notorious factor for development of bladder cancer and industrial exposure of chemicals. If you can cut down on the smoking, that is very much essential, and not just for bladder but for many other cancers in the body. Early sign of bladder cancer is blood in the urine, so please do not ignore any episode of blood in the urine. Get yourself evaluated with the expert opinion for ruling out the bladder cancer. And in muscle invasive and non-muscle invasive phases of bladder cancer, different modalities of treatments are discussed, and mentioned, and the treatment protocols are followed exactly as per the required guidelines or as per the guidelines. Thank you so much.